This conference will now be recorded.
So good morning, everyone. Today we are going to discuss about the infections around the knee joint. So first we will discover the tuberculosis of knee joint. So coming to introduction, so as everyone know that tuberculosis is a chronic granulomatous disease caused by Mycobacterium tuberculosis, and it usually infects the lungs. And pulmonary complications are usually involve the lungs, and the other parts of the body also involved. Skeletal tuberculosis is also involved. And we can see that in all the cases of tuberculosis cases, skeletal tuberculosis accounts for 2% of the all cases of tuberculosis. So it is most common condition in India, and the most common form of skeletal tuberculosis is POTS disease. If the tuberculosis involves the spine, then it is known as POTS disease. So the most common form is the skeletal tuberculosis, POTS disease. The next most common form of skeletal tuberculosis is tubercular arthritis. Arthritis is TB arthritis of knee or hip joint. Okay, out of knee joint is the most common joint affected in the uh, apart from hip joint. Knee joint is the most common joint involved in TB tuberculosis. So coming to knee joint proper, knee joint is, as said earlier, is the largest joint in the body, and it is a superficial joint. It is having the largest intra-articular space, and as I said earlier, it is the third commonest site for osteoarticular tuberculosis. First is spine, next is hip, and third is the knee joint. And it accounts for 10% of all skeletal tuberculosis lesions. So coming to pathology, initially initial focus may be in the lungs. So parenchymal disease may be there. The patient may be get treatment for parenchymal disease, and later there may be dissemination from the parenchymal disease to the hematology. There may be hematology spread from the parenchyma to the other organs in the body, and there may be hematology dissemination to the synovium. So initial focus in the as a knee as a proper. Now we are discussing only about the knee joint. So it may be a blood spread. Hematogenous dissemination may be there. Initially, the focus of infection of tuberculosis may be in the synovium, or it may be intraarticular, or it may be extraarticular. Okay, if it is intraarticular, it may be hematogenous dissemination into synovium. If the synovium get infected, the tubercle bacillus get dislodged there and get forms a chronic inflammatory reaction. So sometimes if it is a osteomyelitis, or the subchondral bone is involved, so it may enter into the joint. Okay, subchondral bone, if osteomyelitis is there, then it may involve the joints. So the initial focus may be a blood spread from parenchyma, or it may involve the surrounding bones, bones, may lead to osteomyelitis of bones, and it may develop in the joints. So this usually the pathology is that the synovial lesion may dissemination of tubercular bacilli in the synovium, and they form lesion, tubercular lesions, and mainly for many months to years they may mainly remain as fully confined to synovium. So it is known as tuberculous synovitis. So in the what happens is the synovial membrane get congested, irritated, and studded with more number of tubercles. So when you see for a naked eye, this appears as a pinkish blue or pinkish gray in appearance. So the synovial lining becomes hypertrophic and edematous and with granulation tissue. So this joint, this synovial thickening and all these things, and produces some exudate into the joint. The joint fluid in initial stages So this is very increase in a serious opalescent yellowish in color, and it is very fibrinous in nature. So in early stages, only synovium gets involved. In the advanced stages, the underlying bone is also get involved. So cartilage and bone is also involved. So becomes this in the advanced stage of disease, the tuberculosis process become osteoarticular. The tuberculosis granulation tissue like pannus erodes the articular margins, destroys the bone, and involve the crucial ligaments, periarticular tissues, capsules, and ligaments. So everything in the joint gets involved. Okay. So if the only synovium of the knee joint is involved, then it is stage of synovitis. And if it get involved, if the bone is also involved, then we can see the features of osteoarthritis. Okay, and this surrounding ligaments, cruciate ligament. We have medial collateral ligament, lateral collateral ligament, and anterior and posterior cruciate ligaments. This also gets involved, and they become lax. So they become lax. The and capsule and ligaments are also involved. So we can see in late stage these all are involved. So in a case with the osseous lesions, if the bone is involved, we may see the tuberculosis abscess in subchondral bone or epiphyseal bone or a metaphyseal region. So if the bone gets involved, then the infection spread from the bone to the nearby joint. So it may be, so the lesion may be in the subchondral bone, in the long bone, or in the epiphyseal bone, or in a metaphyseal region. So this form abscess, and this abscess may break the cartilage and enter the joint. Abscess in the epiphyseal metaphase may sometimes be traversing the epiphyseal cartilage base. This is especially in the case of children, the epiphyseal plate is not closed. So sometimes the abscess may traverse this epiphyseal cartilage plate and may enter the joint. So coming to clinical features, the onset and course is insidious in onset. So they can come with the complaints of pain, which is insidious in onset, not very sudden, as in we see in a trauma. It is insidious in onset, gradually progress in nature. And this on examination we can see the swelling. If the knee joint is involved and there is a effusion in the knee joint, we can see the swelling. Okay, and the knee shows swelling, which is warm, and the patellar tap is present in synovial effusion. And there may be sometimes the swelling may be due to thickened synovium. As we see that the synovium get involved, the thickened synovium may be there, and or the swelling may be due to thickened synovium or due to synovial effusion. So if the swelling is there, then we consider that there is a fullness of parapatellar fossa, and mostly medial parapatellar fossa is involved, and we can appreciate this at earliest. So we can swelling is there, then we can elicit tenderness on a pressure, and we can see a synovial thing. We can elicit a tenderness on pressure on the joint lines, medial joint line and lateral joint line, and we can patellar tap is positive, tenderness is present, and so in early stages of synovitis infection, that is stage of synovitis, we can see gross swelling and tenderness along the joint lines. So when advanced stage, in advanced stage, we consider pain. It is very painful, and movements are very grossly restricted. So in advanced stage, we can see the gross atrophy of muscles, that is the thigh muscles, and sometimes we can see the regional lymphadenopathy. Popliteal lymph nodes get enlarged, and we can see the inguinal group of lymph nodes also gets enlarged in the case of TB knee joint. So as I said earlier, there is a gross wasting of the thigh muscles, usually quadriceps muscles. So if it is in advanced stage and we are not giving any medical treatment, and and we are neglecting the case, then we can see the deformity known as triple deformity. What is known as triple deformity? In neglected case, we will see it in a triple deformity. In triple deformity, we see there is a flexion at the knee joint, external rotation of knee joint, and valgus deformity at the knee joint. Flexion, external rotation, and valgus deformity at the knee joint. So this is known as triple deformity, and we will see the posterior subluxation of knee joint. So triple deformity, we will see flexion at the knee joint, posterior dislocation of knee joint, and for posterior dislocation of knee joint and external rotation of knee joint. So this is a typical. We can see triple deformity in other conditions also. One is tuberculosis, other one is rheumatoid arthritis, other is hemophilic arthritis. So in other conditions also we can see triple deformity. So this is very specific for a knee. This one, tuberculosis of knee joint. So you can also see it in the case of this one, iliotibial band contracture also. So once the flexion deformity gets established, so there is a contraction of tensor fascia lata, and this later accentuates the deformity. In long-standing cases, this posterior capsule of knee joint gets contracted. Contracted, so there may be a posterior subluxation of tibia over femur. So coming to how will you diagnose a case of tuberculosis? One is we'll go with the routine investigations. We'll take if the patient is known a case of a pulmonary tuberculosis, we'll take a chest X-ray. We'll confirm that the parenchymal changes are there, and we'll go with the Montu test, and if any PCR for a tuberculosis bacillus and a CB-NAT. So for the case of TB knee joint, we'll go with the X-rays and with the general routine investigations. So in X-rays, we will order for the AP and lateral view. So we have to differentiate whether on X-ray with a synovial stage or a stage of arthritis. So in a synovial stage, what happens in a synovial stage? There is a effusion in the knee joint, and effusion in the knee joint. Then there is a soft increase synovial thickening. So we will see an increased soft tissue swelling in the X-rays, and joint spaces increase. Joint spaces increase, and there is a increased soft tissue shadows in the X-rays. So it is increased soft tissue swelling may be due to synovial effusion or thickened synovium capsule. Some we will see generally osteoporosis of distal femur and proximal tibia. So osteoporosis is seen in the distal tibia and distal femur and proximal tibia. So in the stage of arthritis, so as arthritis set in, so there is a loss of definite articular surfaces, and there is a marginal erosion of the bone. So there is a diminution of joint space, and there is a destruction of bones from the forming the joint. So we can see there is a diminution in the joint space, and we can see marginal erosion, and surrounding bone get destroyed. So you can clearly distinguish between the synovial stage and arthritis stage. So in advanced arthritis, we can see cross destruction deformation of both ends. You can see cavities, osteolytic cavities in the distal end of femoral proximal tibia, and we can see tuberculosis sequestra, and we can see in excess deformity. Usually, we can see the flexion and flexion deformity and valgus deformity in the an advanced stage. So this is the X-ray showing knee joint, TB knee joint with valgus knee. So this joint is involved, and we can see the deformity here. Here, this is a valgus deformity of knee joint. So coming to differential diagnosis of tuberculosis arthritis. So monoarticular affections of affection, that is rheumatic arthritis. Rheumatic arthritis in children, or chronic traumatic synovitis. So chronic traumatic synovitis may be due to trauma like meniscal tear, a loose body, osteochondritis dissecans, chondromalacia patella, or discal semilunar cartilage. Sometimes other differential diagnosis will be the rheumatoid arthritis. Rheumatoid arthritis and subacute pyogenic arthritis or synovitis. So hemophilic arthritis, rheumatoid arthritis, hemophilic arthritis, and in a dysenteric arthritis, villonodular synovitis, synovial chondromatosis, synovium, foreign body granuloma. Mostly we have to differentiate it from septic arthritis or rheumatoid arthritis. Septic is something that is acute condition. It is a chronic condition. So we have to differentiate it from rheumatoid arthritis and tuberculosis arthritis. So what is the prognosis? So, with the introduction of anti-tubercular drugs, medical management, the prognosis is good if you treat this early. So Lee et al. In 1995 and Hoffman et al. In 2000, with the modern methods of management of functional results are directly related to extent of disease at the onset of anti-tuberculosis drugs. So as early as possible, you have to start with anti-tuberculosis drugs. So what are the anti-tuberculosis drugs? Isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. So in a stage of synovitis, you have to decide whether we have to go for operative treatment or non-operative treatment. So it depends. If we are going for a non-operative treatment, we have to treat it medically with anti-tuberculosis drugs, and we have to give flexion. We have to attend flexion at the knee joint with braces or traction. And we have to, if the symptoms progress, then we have to go for operation. Operation for synovitis is synovectomy. So there will be a complete healing and excellent range of movements. So early we treat the patient, better the results. So in advanced case with subluxation and severe restriction of motion, so the prognosis is somewhat bad. So if the very severe restriction of motion, we have to do arthrodesis in functional position, that is 5 to 10 degrees of flexion. So as we have discussed earlier, and coming to treatment part, one is a non-operative treatment, other is an operative treatment. In operative treatment, these are the procedures we do. We do a synovectomy, joint debridement, and something called a arthrodesis and arthroplasty. So non-operative treatment. So non-operative treatment is nothing but medical management. We'll give a non-operative treatment anti-tuberculosis drugs. These are employed in tuberculosis, synovitis, and in children. So as I said earlier, anti-tubercular drugs are for if any skeletal tuberculosis involved, it is given for at least 9 to 1 year. So we have to apply, we have to relieve the pain. We have to relieve the pain. So we'll go with anti-tuberculosis drugs and then non-steroidal anti-inflammatory drugs. So and we'll apply traction. Why is traction applied in the case in this case? So we want to avoid flexion and subluxation deformity of the knee joint. So this traction helps to keep the joint in minimal flexion or in extension. So keep the joints well distracted. So we want to avoid flexion and deformities at the knee joint. So we are applying traction. In addition to systemic drug, the joint can be maybe aspirated. If the cross swelling is there, then we can go for joint aspiration. So if the acute local signs are reduced, then we can go with a gentle, active, and assisted knee bending. mean physiotherapy. You can go with a physiotherapy, active and assisted knee bending exercise. So after 12 weeks, that is 3 months, if the patient is doing well, we can go with a permitted ambulation with suitable arthrosis or crutches. And after 6 to 12 months of treatment, in the case of favorable response, so first after 12 months, after 1 year, we can remove this crutches and orthosis. So initially, if there are local signs of infection, we'll go with the skeletal traction or a skin traction. And if the acute local signs are reduced, we will go with the physiotherapy, knee bending exercise. That is active and assisted knee bending exercise. And we will not ask the patient to mobilize for at least 3 weeks. We'll see the response of the anti-tuberculosis drugs and drugs. And after 12 weeks, that is 12 weeks, that is 3 months, we will ask if the patient is doing well and is recovering, then we will ask him to weight bear, means permitted weight bearing. We will ask him to weight bear with the help of orthosis or crutches. And if he is doing well, and if he's doing well after 3 months, and after 6 to 12 months, we will observe the patient and we will ask the patient to bear full weight after that. So after that, with the help of and we will remove the crutches and orthosis after 12 months. So unprotected weight bearing, if the patient is doing well, unprotected weight bearing is permitted after 9 to 12 months of the start of treatment. In children with arthritis, the deformity and subluxation corrected by, in children, it is deformities are in the subluxation corrected by employing double traction and rarely by corrective plasters. In adults, we can apply that central traction. In children, we have to apply double traction, and sometimes if the children are very small, we can go with the corrective plasters. So in children, we don't do arthrodesis. We don't do arthrodesis in the case of arthrodesis of grossly destroyed knee in children should be deferred till completion of growth potential for a distal femur and proximal tibia. So we won't do arthrodesis in children. Once the maturity, child achieves maturity and all the proximal tibia and distal femur get all the growth potential is completed, then we will go, we'll plan later. So in children, we won't go for arthrodesis procedure. In operative treatment, what are the different modalities of operative treatment? As I said earlier, we have synovectomy. Synovectomy is nothing but remove synovial tissue and debridement, and later arthrodesis and arthroplasty. So in initial stage, in early stage of synovial stage, we'll go with arthrotomy. Arthrotomy is nothing but opening of joint, and synovectomy is nothing but remove all the synovial disease synovial tissue is carried out. This, along with the anti-tubercular drugs, is a treatment choice in the case of early synovial stage. In the case of early arthritis, again we will do arthrotomy and we will do synovectomy, and we will remove all the loose bodies and raised bodies, debris, pannus, and the loose articular cartilage, and we will carefully curatize all the osseous juxtaarticular foci. So in addition to the synovial tissue, we will do some amount of disease bone here. So post-operatively, what we'll do is we will continue anti-tuberculosis drugs and analgesics, and we will continue traction, intermittent active and assisted exercise, and we will continue with the suitable braces for ambulation. So this is for early stage of arthritis and synovitis, stage of synovitis. In adults with advanced arthritis, the final sequel of this tuberculosis knee joint is fibrous ankylosing. So in adults with advanced arthritis or in cases with resultant fibrous ankylosing during the process of healing, the knee joint may be treated by arthrodesis. In the adult cases, we will go with if it is very severe and all the joint is destroyed, then we'll go with the arthrodesis. So why are we opting for arthrodesis? So what we want with what is the aim of arthrodesis? So we want a painless, stable knee. So we want painless, stable knee, and we want to correct the deformity and prevent recurrence, re-emergence of this infection. So for this case, we will go with the arthrodesis. So, so with arthrodesis, the patient is pain-free and he can do long hours of standing and walking. And it should be arthrodesis should be done in the position of it, that is 5 to 10 degrees of flexion. In the case of an arthrodesis, what we do is we open the joint and we remove the distal end of the femur and tibia, and we approach both the raw surface of bones of distal femur and tibia together, and we apply compression clamp. This compression clamp is known as Charnley's compression clamp. So after the bone union, if the after bone union it takes place, so you can start walking without pain in extend limb in 5 to 10 degrees of flexion. But what are the limitations of this arthritis? He can't flex and extend on knee. So there are a lot of restrictions. He can't squat, he can't sit, and is having difficulties in public transport and many other social activities. Just we can remove the main thing we can do with this arthrodesis is we can remove the pain, the painless stable knee. So previously it was told that we won't do arthroplasty in the case of TB knee joint, but there are some reports that Besser and Wray and Roy performed the arthroplasty inadvertently in a preoperatively unsuspected case of tuberculosis of knee. So they attained good results. Kim reported good results after total knee replacement, selected a case of old healed tuberculosis of knee. So Gale and Harding, all these persons told that total knee replacement can be done in the case of tuberculosis of knee, and the results are good. So what are the indications for when the patient get infected with tuberculosis arthritis of knee? So what are the indications for arthroplasty? So at present, a replacement arthroplasty of knee is being offered to selected patient. This operation should be done after 5 to 10 years after last evidence of acute infection. So if a patient comes with you with a tuberculosis arthritis of knee joint in advanced stage, so we are dealing with medical treatment, anti-tubercular drugs, and we will see that there is no tubercular infection. It get eradicated, and afterwards, after 5 to 10 years after treatment, we will go with this arthroplasty. So when we go with arthroplasty, that is total knee replacement, we will advise the anti-tuberculosis drugs around this pre-operative, post-operatively around after replacement surgery. So this is about replacement. This is all about TB knee. So how will you differentiate this tubercular osteoarthritis of knee from septic arthritis? Septic arthritis is an acute condition of knee joint. Usually we can see the septic arthritis in the case of infants and children, and rarely in adults. It usually presents with a acute onset of pain, and there is a gross swelling, and there is redness around the knee joint. Redness around the knee joint, and we can see the symptoms like high grade fever, malaise, etc. And so the most common cause of septic arthritis is staphylococcus aureus and streptococcus, and sometimes you can see gonococcal arthritis also. So this is a insidious in onset in nature, whereas in septic arthritis is a acute in onset. So this is how we can differentiate between clinically differentiate between a septic arthritis of knee joint and tubercular arthritis of knee joint. Thank you.